y'all, it's your girl Ashley, and you're listening to Sex with Ashley podcast, where we talk about pleasure, sex, relationships, and how to feel confident in your body without the shame. If you're ready for real talk with real tools, you're in the right place. Now let's get into it. All right, welcome to another episode. I am your host, Ashley Cobb, and today we are talking about sex after endometriosis. My guest here is Lillian. Hi, Lillian. How are you?
I'm good. Thanks for having me.
Thanks for being a part. So we're going to get right to it, okay? So I want you to tell me tell me who you are, what you do, and then tell me why you want to talk about endometriosis, and then we'll expound from there.
Yeah, sure. So my name's Lillian Medhus. I am a women's health nurse practitioner and a nurse midwife. I own a boutique women's health practice in the Dallas area. And I have a history of endometriosis and chronic pelvic pain, along with some other chronic illnesses like thyroid cancer and autoimmune disease. And so I really want to get the word out there because I know for myself, I suffered for a long time, not knowing what was going on or thinking this is how it's supposed to be. And so I just want other women to know that they don't have to suffer and that there's treatment available for them.
Okay, so for people who don't know what endometriosis is, can you explain what that is?
Yeah. So endometriosis is a chronic disease. It is often associated with very heavy and painful periods, often also associated with things like pain with sex, GI upset. A lot of times we see patients diagnosed first with IBS and then later find out they have endo, bladder issues as well, and fatigue come along with it. And it's characterized by cells that are similar to the lining of the uterus, but they're outside of the uterus. So symptoms depend on where those cells are. So you may have pelvic pain if you have a lot of adhesions in the pelvis, bladder pain if there's adhesions on the bladder, and they can actually be found all over the body.
Okay. So how is sex for someone who has endometriosis?
Yeah, it really varies. Some people never know they have endo, and they don't find out until they are having trouble conceiving. So there's a subset of people that, we say they have unknown cause of infertility. And sometimes that cause is because of endometriosis and they never knew. However, it is associated for a lot of people with having pain with intercourse, especially with penetration and deep penetration, because it can cause really tight muscles in the pelvic floor that make it more uncomfortable.
Okay. So I guess for you, since, we're talking about sex after endometriosis. So one, I guess, how did you know you had endometriosis? Was it because sex was painful? Was that the first clue?
No, actually. So for me, my cycles were very painful my whole life. And I, at the same time as I'm dealing with these really heavy and really painful periods, I'm also going to grad school to be a women's health nurse practitioner. And a lot of times there's this thing of providers are the worst patients, right? And so I was just dealing with it on my own. I did not even have my own women's health provider because I thought, I can do this by myself. And so I was kind of self-treating with over-the-counter pain medications and heat and TENS units and diet changes and that kind of stuff. And at the same time, I did have chronic pelvic pain and pain with penetration. But I kind of was in this mindset of I don't think anything can really help me and I just don't have time for that. Maybe this is just how it is for everyone and I just need to buck up. I'm just not tough enough like other people are or something like that. And so it wasn't until I actually had a lot of other health kind of crises come up. Then my cycles were just getting worse and worse. And so I started having really bad left-sided pelvic pain to the point that I wasn't able to work. I wasn't able to do things. And I was like, okay, now I need to go in and get seen. Meanwhile, at work every day, I'm taking care of all these people with endometriosis, which is just the irony of it, And so I go in and they do an ultrasound, and there's something called an endometrioma, which is a cyst on the ovary that is filled with endometriosis tissue. So usually you can't see endo on an ultrasound. We only see it on surgery. But once in a while, if you have one of these cysts, then we can say, well, yeah, you probably have endo. And so from there, I had surgery to remove the cyst and to excise a lot of that endometriosis, and then have been in kind of the healing path since then.
Okay. So since your surgery and since removing the cyst, how has your sex life changed?
Yeah, so it's only improved. So a lot of providers will say like the diagnosis is the cure or is one of the cures for endo, like finally having a reason for the pain for many people, including myself, kind of gives you permission to seek treatment, right? Like you're like, oh, okay, it wasn't in my head. I wasn't just being dramatic. Like there is a reason why this is going on. And so thankfully, like I'm on medication now, my cycles are much better. That makes a huge difference. And then I started pelvic floor physical therapy to help with those tight muscles that have been kind of in response to endo. And through that have been able to find a lot of healing, like I'm not having pain anymore. And that then like opens up kind of the window for exploring like pleasure and just like enjoyment of my relationship.
Because I know someone who has endo, and she was saying how I don't believe she had surgery. Mm-hmm. She was just saying how pelvic floor therapy helped her. Mm-hmm. So can you go into detail, or can you discuss how the options, if someone doesn't want to get surgery, the surgery option, how can pelvic floor therapy help or assist?
Sure.
And what is pelvic floor therapy?
Yeah. So pelvic floor physical therapy is a great addition. I work very closely with them in my work. And they are literally physical therapists for your pelvic floor. So if you don't know, like anatomy wise, your pelvic floor is like a bowl that is supporting the whole upper half of your body. And so when things are going on, whether that's like low back pain, and now your pelvic floor has to tense up because your back isn't able to support you the way it's supposed to, or whether it's endometriosis where you have a lot of inflammation, a lot of pain that causes those muscles to tense up. And over time, they just become more and more tight and more difficult to manage. So PT, they do a lot of different things. They may use manual therapy, which is inserting their finger and manually releasing those muscles, just like if you were to get a massage of tight knots in your back. They do sometimes dry needling, which is where they take a needle in those tight muscles, sometimes in your hips, your butt, your pelvic floor, to help release them. Lots of home exercises. So for me, a big focus was I had plantar fasciitis. And so when you have this pain in your foot, then everything works up, and so that was contributing. And then I had some hip pain that was contributing to tight muscles. So we did exercises to work on that. They work a lot on the nervous system as well. So like helping you to kind of down regulate, not carry so much stress in your pelvic floor. So it's a combination of things depending on what the person needs. Yeah.
Okay. So what is the biggest difference you can tell in your sex life since being treated for endometriosis?
Definitely not having pain. So I used to have so much pain that, it made it difficult to manage. So, and that like removal of pain then allows for more desire. It allows for more enjoyment. But I always tell people like, if, you love ice cream and then you eat an ice cream and you get really sick, you're never going to want to eat ice cream again, right? Like it's the same thing. Like you might love your partner, but if it's so painful, like your body naturally is not going to want to go back to that.
So I hear sometimes people say, a lot of times with women, if they're with men or whatever, or married to or dating men or having sex with men, sometimes men feel like, oh, you're just making excuses, or you're just not in the mood, mm-hmm. or you just whatever. Like I don't believe mm-hmm. The person. So what would you what would your advice be to someone who is experiencing painful sex? Maybe endometriosis, they're not sure, but maybe they do have it. How do you talk to your partner about it?
Mm-hmm. Yeah. Well, first thing I tell people is like, you are not ever in any way like entitled to sex. So that's what I would tell their partner. No matter like what your relationship status is, how long you've been together, how bad you think you need it, you're not entitled to anyone else's body. And so I tell my patients that too, like marriage does not, or long-term relationship does not entitle someone to someone else. So that's like first thing. And then from there, what I do a lot of times is I will bring in, if they are comfortable with it and they are in a, secure relationship, they will bring their partner in with them and I teach them together. And so what we do is we do an exam and we see like, okay, you have a tight muscle right here. And when I push on it, it's painful. And that's the same pain that you have when you have sex. And so I show them like, just like if you had a tight muscle in your neck, if you had someone pushing on it really hard, that's going to cause pain. It's the same thing. So that's something I do a lot, is just like educating on how the pelvic floor works and why they might be having pain. Too, a lot of times it's not something like medical per se, but women need, usually, I should say, 90% of the time, women need clitoral stimulation prior to penetration. And so if you're not, stimulating the clitoris, if she's not having an orgasm first, ideally, then penetration is likely to be more uncomfortable.
So have you found, sorry to cut you off.
No.
Have you found that with patients of endometriosis that if a clitoris is stimulated before penetration, that is a better experience?
For most people, there are a subset of people that have more pain with orgasm because of the uterine contractions. So just like they have more pain on their cycle. However, most people, even with endo, will do better with orgasming first before having penetration.
Okay. Cool. Okay. I didn't know that. I didn't know if it. I know that mattered. Mm-hmm. I know it matters overall.
Yeah.
For women, I know that much, but I didn't know. I just assumed that it's painful beforehand or not. So that's cool. Mm-hmm. This episode is brought to you by Pleasure Please, my book that helps you build confidence, communicate your needs, and reclaim pleasure without shame. Available now on Amazon, Barnes & Nobles, and wherever books are sold. So could a maybe at-home remedy be during sex to make sure that you orgasm before sex all the time?
Ideally, yes. And, it may not be the cure. Like if someone has really tight pelvic floor muscles or they're not on any kind of treatment for endo, that may likely not be enough, but it should always be one of the building blocks.
Okay. So is there anything you can do at home first for treatment? And if so, what are those things before going to a doctor?
So for treatment for endo, specifically, there unfortunately is not a lot that can be done outside of medical treatment. There are things you can do for the pain, like ibuprofen and Tylenol and heat and TENS units and, anti-inflammatory diet. But for pain with sex that may or may not be associated with endo, there's a lot you can do. So biggest one is communication with your partner, understanding your own body, understanding what you like, and communicating it. Using lube, like everyone should be using it. Dilators can be very beneficial. And that's something that often a PT will work with you with, but you can certainly try it before going to PT.
And so what's a dilator?
Yeah. Yeah. Dilators are medical devices. They're silicone. They come in a range of sizes and they help to stretch and relax the pelvic floor. And so they're used for people that have really tight pelvic floors. Sometimes you might feel like a burning, itching feeling at the opening of the vagina, or you might feel pain really deep inside. And so the dilators, you work up from smallest to largest to help stretch and release those tight muscles.
Okay, so are dilators something that you can do on your own, or that's only that you should do under the treatment of a medical provider?
You can do them on your own. Yeah. Some people will do fine just getting them and working with them. And some people, especially if the pain has been long lasting and they have that kind of fear component going along with it, like fear that it's going to be painful, they may get better faster working with someone, but they can certainly try on their own.
Okay, good. So outside of endometriosis, I know you work with a lot of women who have painful sex. What are some other causes to painful sex?
Yeah. Outside of that, the number one cause that I see is low estrogen. So low estrogen in the vagina causes vaginal dryness, irritation. It makes that vestibule, that part right at the opening, really tender. And that can happen when someone is breastfeeding, when someone is on oral birth control pills, or when they're in peri or postmenopause.
Okay. And so if you're someone who has low estrogen, you should use lube. Well, first, I think everyone should use lube.
Me too.
But if you're someone who has low estrogen, you definitely should use lube. And is there something else that you can do to counteract?
Yeah. We love low dose vaginal estrogen. So it's the gold standard. It's safe for everyone, regardless. It just works in the vagina, so it's local. It doesn't increase your blood estrogen levels. And it's a cream that you put in the vagina and on the clitoris, and it changes people's lives within a couple of weeks.
Ooh. And it's a cream.
It is, yeah.
So this is a cream that's prescription based, or can I go like to CVS and get it?
It's prescribed. Mm-hmm.
Okay, that's a good idea. That's a good tool and to have in the toolbox.
Yeah.
So what other things you see as a nurse practitioner with women that you think would be prevalent to this conversation?
Let's see. I think other things that are common for women are just kind of like the overlap of, hormone changes, whether that's postpartum, whether that's starting a new birth control, or whether it's peri and postmenopause, and kind of like the downstream effects of that, and then how they kind of internalize it. So I'm always trying to like normalize these stages of life and say like, we can help you have a great sex life, even when you feel like your body is changing drastically.
Okay, let's talk about each one of those right quick. So let's talk about, you said postpartum. So how does postpartum affect sex lives with your patients that you've seen?
Yeah, most, not all women postpartum, their sex drive will likely go down for a time period. And that's for several reasons. One, your estrogen levels when you are postpartum and breastfeeding are the same as they are when you're postmenopausal. That is a huge shift. So they're the highest when you're pregnant, the lowest when you're postpartum. So that makes a huge difference. Not to mention sleep disturbances, stress, new, expectations on the relationship, and then potentially needing some pelvic floor healing after giving birth as well. And a lot of women come to me and they're like so distraught, or they didn't see it coming because no one really talked to them beforehand about what their sex life might be like afterwards. And so we really try to like normalize it, work on the things that we can work on, and also know that it's going to be an evolution over the next probably 1 to 2 years. Things may change again.
Okay. So let's talk about perimenopausal. So people who are perimenopausal, one, what typically age range is that? And what should they look forward to, I guess, positive or negative? What should you look forward to in being perimenopausal, and how that could potentially change their sex life?
Yeah. So it's a lot younger than a lot of people think. Sometimes my patients think that I'm like attacking them when I tell them it might be perimenopause because we think like that's our grandma or something, But a lot of times perimenopause can start in the late 30s, early 40s. So the average age of menopause, which means 1 year of no periods at all, is 52. However, perimenopause can last up to 10 years prior to that. So in some women, that is late 30s, early 40s, that they may start to notice some changes. A lot of times people,
What changes do you notice?
Yeah.
What changes happen so that way you can say, oh, I made perimenopause, or what happens?
Mm-hmm. A lot of times it's changes to the period. So they're like, it's just a little bit longer, a little heavier, or it's a little bit more spaced out than it used to be. Brain fog is a big one. I have people come in and they're like, I think I have Alzheimer's. And I'm like, no, it's not Alzheimer's. Thank goodness. It's perimenopause. We see changes in like energy levels sometimes, body aches and pains, vaginal dryness, like I was talking about, sometimes urinary incontinence or frequency, libido kind of changes in some people. And then later on tends to be those more common things you think of, like hot flashes, night sweats, mood swings, that kind of stuff.
Okay. And then after perimenopause, menopause. So have you noticed that people's libidos changed after menopause? Have they skyrocketed? Or during perimenopause, is your libido, is it higher, tend to be lower? Mm-hmm. And then if it's lowered, when do you get back on the uptick?
Mm-hmm. Yeah, so it's kind of interesting. In general, the decreasing hormones, estrogen, progesterone, testosterone, causes your libido to decrease. It also, like I was saying, causes issues with orgasm and vaginal dryness. However, on more of like the psychosocial side of things, a lot of times women in their 40s, 50s, 60s are finally like shedding some of the shame, coming into their own in their bodies, know what they like, know how to communicate that with a partner. And so in that way, they may be having better sex, but maybe not wanting it as much as they used to. But yeah, studies show us that actually women postmenopausal rate their sex that they are having as better than it was when they were younger.
Ooh, that's good. Why do you think that is?
I think that it has a lot to do, now this is just my personal opinion, but seeing a lot of women, I think that as we age, we start to let go of a lot of those like societal expectations. And we're like, no, I can take up space and I deserve to enjoy the sex that I'm having. And so they start to kind of own that a little bit more.
And so I was talking to some other ladies who were also older and who said 160s, 150, and said that as they got older, they had better sex. And they attributed that to just not caring anymore. Mm-hmm. Like they just like, okay, I know who I am. I'm no longer trying to be whatever me, take it or leave it type of thing.
Yeah.
Also, their kids tend to be grown, so it's not like I have to uphold this image for my children. Yeah, so they tend to. So I agree with that. And from the people that I've talked to, they all say the same thing. Yeah.
Yeah. So, it's awesome if you're coming into your own in your body, and then, we can use hormone replacement in some cases to kind of help mediate the uncomfortable side effects that you're having. Then many women go on to have thriving sex lives as they age.
What would you say somebody who is nervous about hormone replacement therapy?
Yeah. So first thing, like if you are concerned about vaginal symptoms, like your difficulty with orgasm, dryness, vaginal estrogen is a great option. Like I said, everybody can use it. It does not increase your risk of any complications because it's just local, right? It's kind of like skincare for your vagina. As we age, we need different skincare. We need skincare down there too. If you're wanting systemic hormone therapy, whether it's estrogen, progesterone, testosterone, so they're used to, well, let me say, do you want me to get on my soapbox about this?
Yeah, go ahead. Yes.
Okay. Have you heard of the Women's Health Initiative? It's a big...
I want to say I have.
Okay. It's a big study that was done like 20 years ago.
Okay.
Lots of women were in it, few thousand. And what they did was they were looking at what are the complications of hormone therapy, if any, and benefits. And so they took this group of women, mostly postmenopausal already, some by a lot, like 10 years or more. So their bodies aren't used to having estrogen anymore. And they did not stratify them. So they didn't say, what are their risk factors already? What's their smoking status? What's their previous health history? What's their family history? They just took them and put them in one big group. And then they started this study where they put people on estrogen and progesterone. And back then they were using high dose oral estrogen and oral progestin, which is like a chemical version of progesterone. It's not what's in our body naturally. And what they found was that people that were on estrogen alone had no increased risk of breast cancer. They actually had a decreased risk of breast cancer. And people that were on estrogen and progestin had a slightly increased risk of breast cancer. It went from 1 in 8 to about 1 in 8.001. So what actually happens though, right? When this study comes out, they stop the study and it goes to the media. And what does the media say? They say hormone replacement therapy causes breast cancer.
Breast cancer.
Yes. And then they take 90%, something like that, percent of women off of it. And it's just now finally that we have a lot of good data to show that estrogen and progesterone therapy, the way we use it now, likely does not increase risk for breast cancer. And other risks, need to be looked at. There may be a slightly increased risk for blood clot for some people. However, it decreases the risk likely of osteoporosis, possibly heart disease, and Alzheimer's. And so we have to look at the risks and the benefits of those things.
That's good. That's really good. So for people who were on the fence about it or like, I don't know, that's really good. That's really good information to know.
Yeah.
So what would you say to someone who, is experiencing painful sex but just hasn't gone to the doctor yet?
Mm-hmm.
What would you say to them?
Yeah, I would say that it's really common, first of all. At least 1 in 10 women experience this, likely more, but we just, aren't talking about it. 2, I would look for a provider that is comfortable talking about sex. Just because someone is an OBGYN does not mean that they necessarily are comfortable talking about sex or share your values when it comes to sex. So that's another one. If you feel like you were, not validated by a provider, keep looking. Like, we are out here. We are trying to help people and know that there are treatments for it. So you don't have to suffer. You can find healing from it.
That's good. So if someone is listening to this and they want to just reach out to you directly, do you have a social media that they can DM you or send you some questions if they have?
Yeah. My clinic is called Aspire Women's Wellness. So our Instagram is just at Aspire Women's Wellness. And then our website is the same, aspirewomenswellness.com.
And you're in Dallas, correct?
Yeah. So we have in-person services in Dallas and then telehealth throughout Texas, California, and Minnesota.
Okay. So if someone wanted to, someone was in Dallas and wanted to make an appointment, they can just come by and make an appointment or?
Either call or you can schedule online.
Okay. Ooh. Thank you, Lillian, for being here. I learned so much today about endometriosis. I did not know.
Yeah. Thanks for having me and thanks for the work that you're doing.
Thanks for listening to Sex with Ashley. If you learned something today, do me a favor and send me a review and share this episode. And if you want more guidance, you can also purchase my book, Pleasure Please, available at Amazon, Barnes & Nobles, and wherever books are sold. Love you. Mean it. See you next week.